Hi, so I'm James. I had hepatic injury as the topic for our SCORE lecture today. Um, Starting off with some basic principles. The liver is the largest organ, making it the most susceptible to blunt or penetrating trauma. When a hemodynamically stable, non-peritoneal, or no other indications for a laparotomy, the preferred treatment is with hemodynamic monitoring in the SICU, serial abdominal exams, and serial CBCs in order to check their hemoglobin. Um, the only absolute contraindication to non-operative management is hemodynamic instability. And if you are doing an exploratory laparotomies for somebody who does have uh, a large hepatic injury, the primary goal is to stop the bleed. Starting off with anatomy, wanted to go over the separate lobes, the ligaments that are attached to the liver, which ones you can go through, the foramen of Winslow and its contents, or the contents of the uh, ligament um, around the foramen of Winslow, and then segmental anatomy. Um, so, starting with the lobe or lobes of the liver, they can be split up into the right and left hepatic lobe. We've gone through this before, but the falciform ligament does not separate the liver into left and right. There is a plane from the gallbladder fossa to the inferior vena cava that is known as Cantley's line. That separates the right and left. Now, the right is a little bit denser. It takes about 60 to 70% of the liver mass. And then the left lobe takes, which includes the caudate lobe, takes up the rest. The caudate lobe is to the left and it's anterior to the IVC. And then, once again, the falciform ligament will separate the left lateral and left medial portions of the left lobe. Moving on to the ligaments, there are a couple ligaments that are attached to the liver that keep it in place in the right upper quadrant. Starting with the round ligament. The round ligament is a remnant, or is the remnant of the obliterated umbilical vein, and it enters the left liver hilum at the edge of the falciform ligament. The falciform ligament separates the left lateral and the left medial segments along the umbilical fissure, and then it anchors the liver to the anterior abdominal wall. Deep in the plane between the caudate lobe and the left lateral segment is a fibrinous ligamentum venosum. Um, this is the obliterated ductus venosus, and it's covered by the plate of Arrhenius. The left and right triangular ligaments at the top secure the two sides of the liver to the diaphragm. Extending from the triangular ligaments anteriorly on the liver are the coronary ligaments. The right coronary ligament, in particular, extends from the right undersurface of the liver to the peritoneum overlying the right kidney, thereby anchoring the liver to the right retroperitoneum. All of these ligaments, the round, the falciform, triangular, and coronary, can be divided in a bloodless plane in order to fully mobilize the liver. Moving on, if you were to lift the liver, there are a couple more ligaments in place. There's the gastrohepatic ligament and then the hepatoduodenal ligament. Now, the hepatoduodenal ligament is also known as the porta hepatis, and it contains the common bile duct, the hepatic artery, and the portal vein. From the right side and deep to the porta hepatis is the foramen of Winslow, and it's also known as the epiploic foramen. This passage connects directly to the lesser sac, and it allows complete vascular inflow control to the liver. So when you clamp the hepatoduodenal ligament in the Pringle maneuver, you're clamping the common bile duct, the hepatic artery, and the portal vein. Moving on to the segments of the liver. Um, We have seen it before in just anatomical pictures, but I thought it would be a little bit more useful in a CT scan. So the picture on the left is the more caudal view, and it shows that 2, 4A, 8, and 7 can all be seen within the same plane, along with the caudate lobe denoted as the number 1. And then as you move down, you can see 3, 4B, 5, and 6, and you can um, use this to kind of figure out um, usually the grades for 1, 2, 3, and then we'll go through the grading a little bit later. But I think keeping this picture in mind um, for grading is pretty useful. Now, in order to stop the bleed, it's good to know uh, about the vessels that supply blood to the liver. Um, uh, of note are the hepatic artery, the portal vein, and then the hepatic veins and inferior vena cava. Bleeding can come from any one of these portions. Starting with the hepatic artery, uh, stems from the celiac trunk. Um, so you can see that from the celiac trunk, you have the left gastric artery going up, you have the splenic artery, and then the common hepatic artery. If you follow this as it courses towards the liver, you'll see that it goes into the proper hepatic artery, and then that gets split off into the right hepatic and the left hepatic artery. Now, the hepatic artery will deliver about 25% of the blood supply, and then the portal vein, which runs behind the common bile duct and the proper hepatic artery, um, supplies 75% of the blood supply. One way that they can trick you is by asking oxygen content between the artery and the portal vein. They're equal. They give 50%. 50% of the oxygen will come from the artery, and then 50% of the oxygen will come from the portal vein. But there is also quite a bit of variation when it comes to uh, the blood supply. I thought this slide did a pretty good job showing the differences. So the replaced right hepatic artery from the SMA happens in about 10 to 15% of the time. A replaced left hepatic artery from the left gastric happens 3 to 10% of the time. A replaced right and replaced left is in about 1 to 2% of the patients, and then a completely replaced common hepatic artery from the SMA can happen in 1 to 2% of the time. So a clue that a completely replaced common hepatic artery coming off the SMA is a strong arterial pulse to the right and posterior to the common bile duct. So we know normally that it is anterior and to the left of the common bile duct. This is a good clue to know to be just a little bit more careful. Another important point is that the right hepatic artery passes deep and posterior to the common bile duct about 88% of the time, but the other 12, it will cross anterior to the common bile duct. Next is the portal vein. So the portal vein is a confluence of the splenic vein and the superior mesenteric vein. The inferior mesenteric vein can be seen here, and it looks like it drains into the superior mesenteric vein, kind of, sort of. But it really drains into the splenic vein upstream from the confluence. The portal vein drains splanchnic blood from the stomach, the pancreas, the spleen, small intestine, and the majority of the colon to the liver before returning it to the systemic circulation. Portal vein pressure in a normal person is pretty low. It's about 3 to 5 millimeters of mercury. 20 to 35% of individuals have aberrant portal venous anatomy, with a portal vein trifurcation or an aberrant branch from the left portal vein, supplying the right anterior lobe being the most frequent. Closer to the liver, the main portal vein typically gives off a short branch that's posterior lateral to the caudate process on the right side. And now onto hepatic veins. There are 3 of them: the right, the middle, and the left. They all pass obliquely through the liver to drain the blood to the suprahepatic IVC and eventually the right atrium. In addition, the liver usually has a few small variable short hepatic veins that directly enter the IVC from the undersurface of the liver. The left and middle hepatic veins form a common trunk in about 95% of the time before it enters the IVC, whereas the right hepatic vein does its own thing and inserts separately into the IVC. There is a large inferior accessory right hepatic vein in about 15 to 20% of cases. Runs in the hepatocaval ligament. If you don't have control of this, you can have a ton of bleeding from it. The hepatic vein branches bisect the portal branches inside the liver parenchyma, i.e. the right hepatic vein runs between the right anterior and posterior portal veins. So enough with vessels. Let's talk about the ducts and some nerves. In general, hepatic ducts will follow the arterial branching pattern inside the liver. Just to reiterate, within the hepatoduodenal ligament, i.e. porta hepatis, the common bile duct is anterior and to the right. Now, considerable variation exists, and in about 30 to 40% of cases, there is a non-standard hepatic duct confluence with accessory or aberrant ducts. Moving into innervation. Parasympathetic innervation of the liver comes from the left vagus, which gives off the anterior hepatic branch, and then the right vagus, which gives off the posterior hepatic branch. And a good way to remember this is that in embryology, when your esophagus starts to move distally, it rotates in a clockwise fashion. So your left vagus nerve will go down and it moves anterior, while your right vagus nerves moves posterior. The sympathetic innervation involves the greater thoracic splenic nerves and the celiac ganglia. And then what's not denoted here is the phrenic nerve. And that's important to keep in mind because a common source of referred pain to the right shoulder and the scapula, as well as the right side or back, is that right phrenic nerve. And it's usually stimulated by stretching of the Gleason's capsule or by diaphragmatic irritation. Now onto grading. Grades 1, 2, and 3 are the most commonly seen on CT scan. And this diagram does a very good job of visualizing the liver as you would see it in a CT scan, so that you can make that kind of association. So, lacerations are split up with the numbers 1 and 3. So 1 to 3. Less than 1, 1 to 3 centimeters, or greater than 3 centimeters. Then subcapsular hematomas are split up 10 to 50, greater than 50. So, and then there's also intraparenchymal hematomas that are split up between less than 10 centimeters or greater than 10 centimeters, or an active bleed within the parenchyma. Grades 4 and 5 um, typically are less seen because patients are hemodynamically unstable, which is an indication for an expiratory laparotomy. But if you do see them, usually there's a huge hepatic lobe disruption, um, and 25 to 75% makes it a grade 4. Greater than 75 makes it a grade 5. If there's active bleeding extending into the peritoneum, that can go for either one of them. But grade 5 is when there's juxtahepatic venous injury. So caval, central major hepatic vein injury will give you a grade 5 liver injury. Now, let's talk about the hemodynamically unstable patient, the ones that you have to do an XLAP on. Just to break down the steps before we go into them, the first move you make after you make your stem to stern incision, and then right before you enter the peritoneum, make sure anesthesia is caught up. Uh, you enter the peritoneum. Whatever blood has coagulated, you kind of take out. If there's active bleeding going on, you start packing. You take packing into all 4 quadrants. If it looks like it's coming from the right upper quadrant, you take your finger down into the foramen of Winslow. You do a Pringle maneuver and you clamp and see if that has kind of stopped the bleeding. If it has, then you know it's either coming from the hepatic artery or the portal vein, or from the liver itself. If the patient continues to be bleeding, then you know it's either retrohepatic or the hepatic veins. So the question is always, where is the patient bleeding? And then just so that we know here, these are the areas of vessel injury that can be ligated. The celiac access to the level of the common hepatic artery, the right or left hepatic artery, or the portal vein, they can be ligated. What is interestingly left out of here is the proper hepatic artery. If the proper hepatic artery is seen to be injured, then Schwartz recommended that be repaired at the time. Then I'll go into vascular repairs, and then parenchymal repairs. So if the liver in and of itself is injured. And of note, if you do a right hepatic artery ligation, you also have to do a cholecystectomy at the same time. Cool. Moving on. So this is a picture of what it's like to do the packing. When the right costal margin is elevated, you take pads and you place them over and around the bleeding site. Additional pads should be placed between the liver, the diaphragm, and anterior chest wall until the bleeding has been controlled. Sometimes you have to use 10 to 15 pads in order to control the hemorrhage, especially from the right side. Packing of injuries of the left lobe is not as effective. There's not enough abdominal and thoracic wall anterior to the left lobe to provide adequate compression with the abdomen open. Fortunately, if you have hemorrhage from the left lobe, this can usually be controlled by mobilizing that lobe and then compressing it between your hands. And this is a picture of a Pringle maneuver. If there is persistent bleeding, injuries to the hepatic artery, the portal vein, and retrohepatic vascular need to be considered. Now, a Pringle maneuver can help you differentiate um, the source. Um, so, if you take a vascular clamp, cross it across, and then clamp across the portal triad, hemorrhaging from the hepatic artery and portal vein will stop. Bleeding from hepatic veins and the retrohepatic vena cava will continue. Um, with clean transections of vessels, you should do a primary end-to-end repair. If the injury is destructive, you should do a temporary shunt followed by an interposition reversed saphenous vein graft. Um, Also mentioning blunt avulsions of the portal structures. Um, these are particularly problematic if located at the hepatic plate, flush with the liver. If the avulsion is more proximal at the superior border of the pancreatic body, or even retropancreatic, the pancreas must be transected to gain access for hemorrhage control and repair. Um, I'll get into this picture a little bit later, but if bleeding continues despite repeated attempts at packing, um, uh, and the Pringle maneuver does not stop the bleed, um, then you assume that it's either coming from your hepatic veins or your retrohepatic vena cava. Um, if the patient continues to bleed in that scenario, where you've done the packing, you've done the Pringle maneuver, then you should try to do a direct repair with or without hepatic vascular isolation. There have been 3 techniques used to accomplish this. The first is a direct repair with suprahepatic and infrahepatic clamping of the vena cava, and then staple-assisted parenchymal resection. You can do temporary shunting of the retrohepatic vena cava. And then what is pictured here is a veno-venous bypass. A veno-venous bypass permits hepatic vascular isolation with continued venous return to the heart. Now, parenchymal injuries. Usually, packing will do a pretty good job of slowing the bleed for parenchymal lacerations. Sometimes it doesn't. In those cases, there are quite a bit of topical hemostatic techniques that have been developed, such as electrocautery. You set it at 100 watts, argon beam coagulator, microcrystalline collagen, thrombin-soaked gelatin foam sponge, fibrin glue, and bioglue. You can also suture the hepatic parenchyma. Um, uh, if it's shallow, you can use a blunt-tipped ochromic suture, i.e. a liver suture, in a running fashion to approximate the edges, whereas deeper lacerations are approximated using interrupted horizontal mattress sutures that are parallel to the edge of the laceration. When you tie the suture, you have enough tension when the hemorrhage stops or the liver blanches around the suture. This technique of placing large liver sutures to control bleeding is through reapproximation of the liver laceration rather than direct ligation of bleeding vessels. You can also use the omentum in order to fill large defects in the liver. The tongue of omentum not only obliterates that potential dead space with viable tissue, but it also provides an excellent source of macrophages. Additionally, the omentum can provide buttressing support for parenchymal sutures. Um, Patients undergoing perihepatic packing for extensive liver injuries um, usually go back to the OR for pack removal 24 hours afterwards. Um, you, you go in earlier if the patient has evidence of ongoing hemorrhage. Um, and although febrile patients should be evaluated for infection, patients with complex hepatic injuries typically have an intermittent liver fever for the first 5 days after injury. And then, last but not least, are complications. Hemorrhage and hepatic necrosis um, from uh, artery ligation or just frank liver injury are the most common. Um, Less common are bilomas, pseudoaneurysms, and biliary fistulas. Bilomas are just loculated collections of bile. They can or cannot be infected. If infected, then you treat it like an abscess, percutaneous drainage, etc. Now, small sterile bilomas will eventually be reabsorbed, but if it is large, then they should be drained. Pseudoaneurysms and biliary fistulas are rare. Pseudoaneurysms are best managed with hepatic arteriography and embolization. And then biliovenous fistulas causing jaundice due to rapid increases in serum bilirubin levels need to be treated or should be treated with ERCP and sphincterotomy. One that's not listed here is biliary ascites, and that's due to a disruption of major bile duct. This often requires reoperation and wide drainage. Um, Primary repair of the injured intrahepatic duct is unlikely to be successful, and then resectional debridement is indicated for the removal of peripheral portions of non-viable hepatic parenchyma. And I got the majority of my information from Schwartz, 11th edition. Thank you.